Hello, everyone. This is Dr. Alan Skarbnik. I am the director of the CLL and Lymphoma Program at Advent Health Cancer Institute. I am here joined today by Dr. Paolo Ghia. I will let him introduce himself.
So hello to everyone. I'm Paolo Ghia. I'm professor of medical oncology at Università Vita-Salute San Raffaele in Milan, Italy, where I'm directing the CLL program.
Very good. We're here talking today for the CLL Society, and I'm going to talk a little bit about this abstract that was presented at ASH this year, and Dr. Ghia is the first author. It's about initiating first-line Ibrutinib in patients with CLL, improves overall survival outcomes to rates approximating an age-matched population of 65 years or more. So, Dr. Ghia, can you please guide us to what you and your team did and what the findings were in the study?
Yes, indeed. Thank you for this opportunity. And already starting from the title, I think that the conclusion of our work is rather clear. So it's now more than 10 years that we have novel drugs, novel inhibitors, chemo-free treatment for patients with chronic lymphocytic leukemia. So it is time, we thought it was time to really reevaluate if we ever changed anything really in the perspective, in the life expectancy of our patients. And so we pulled together the data of three major phase 3 studies, the Illuminate, Resonate 2, and the ECOG 1912 that have been already published. And by doing so, we wanted to see if our patient, thanks to the use of the first generation BTK inhibitor Ibrutinib, had an improvement in overall survival compared to immunochemotherapy, but also compared to the how the overall survival behaved in comparison to the normal population, to the healthy population. And from these three studies, we were able to analyze over 600 patients treated with Ibrutinib or Ibrutinib plus anti-CD20 antibodies, and over 400 patients treated with chemoimmunotherapy. And the first results that was, I would say, completely expected is that the 3 and 5 years estimate of overall survival were significantly improved with long-term treatment with Ibrutinib compared to chemoimmunotherapy. And that was, as I said, expected. What was really interesting to show is that the advantage in overall survival, or at least the fact that the patient treated with Ibrutinib had an overall survival estimate that was comparable to age-matched general population. That was true when we analyzed all patients, regardless the age, and in this case the 12-year overall survival estimate in the total population was comparable to the age-matched general population. And when we focused on the elderly patients, who are the majority of patients with chronic lymphocytic leukemia, so patients above 65 years of age, the 8-year overall survival estimate was also comparable to age-matched general population. So really suggesting that with the use of the novel treatment, with chemo-free treatment, we are somehow able to control the disease in a way that the life expectancy of our patients is identical to that of the general population.
Great, thank you so much for the summary. So this is a very important finding, because up to that point we expected patients not to live as long as the healthy patients who don't have CLL. So I think, and I want to know if you agree with me, that solidifies the fact that using a novel agent at first line rather than chemoimmunotherapy for all patients with CLL who need treatment will be the correct approach. And what we see is that they probably live as long as they would live if they didn't have CLL in the first place. Is that a correct assumption?
Yes, indeed. And what I can say, first of all, is that this advantage, for example, compared to chemoimmunotherapy, was independent of any known genetic risk factors, so the immunoglobulin gene status, the FISH abnormalities, and so on and so forth. And the other point that we are now exploring is that if we can also reproduce in patients below 65 years of age, so the young patient, if we can also see if their life expectancy can be comparable to age-matched population.
No, that's a very interesting approach, and hopefully we'll have results of that soon. Thank you so much. Those are remarkable findings, and I think very important for the majority of our patients with CLL who are older than 65 indeed. And I hope most places have access to the novel therapies to be able to provide this kind of treatment for all the patients. So thank you very much for participation today. Thank you for the CLL Society for making this connection. And I thank you so much, Dr. Ghia, for participating today.
Thank you for inviting.
Thank you.